Doctors, welcome to your new world of normal. Your PSG Events app is time-bound, well-planned, and customized to keep you updated on what's new and happening at the forefront of learning activities. This is digital learning in the new normal, your efficient e-assistant that integrates upcoming hybrid go-live webinars and other virtual scientific activities 24/7 at your fingertips, whenever, wherever you are. This app is your new Wattpad for convenient dissemination of timely and relevant COVID-related bulletins that are always handy and readily accessible. To download your new PSG Events app, search PS Gastro Events app and download from Google Play Store and Apple iOS App Store. Create own profile. Fast and easy, convenient and reliable, secured for members exclusive viewing. Be updated whenever and wherever you are. Navigate at your fingertips. The new way of learning in the new normal. Embrace and welcome to your world now. Your new PS Gastro Events app.
Good evening and welcome to the first webinar of the MAESTRO Series, Master Educators in Gastroenterology, in celebration of the 60th year of the Philippine Society of Gastroenterology. The curtains of continuing medical education are rising once again through this online gathering. May we now request all participants to go on speaker view to better appreciate the webinar. And if you have questions, to please type it using the Q&A box. Before we begin the program, let us pause for a moment of prayer to be led by Dr. Roy Gonzalez, Board of Directors of the Philippine Society of Gastroenterology.
Let us put ourselves in the presence of the Lord. Heavenly Father, we thank you for bringing us together today and giving us a chance to enrich our knowledge through this virtual scientific gathering. Open our minds as we are blessed with information and insight, and open our hearts as we aim to use what we learned today to be of better service to more of our patients. Make us instruments of our love in your journey as medical practitioners. All this we ask this in your holy name. Amen.
Thank you, Dr. Roy Gonzalez. Once again, welcome to the MAESTRO Series, Master Educators in Gastroenterology. It is our privilege to be joined tonight by the President of the Philippine College of Physicians, Dr. Mario Panaligan.
Good evening. I hope you are all doing well and staying safe. The pandemic has drastically changed the way we live today. It has enveloped the world in fear, anger, grief, and anxiety. Despite this, there are always a few bright spots that we hang on to. For some, it is being with the family. For others, it is the blessing of technology so that they can work or study from home. To most of us, it is prayer and faith that this health crisis will soon come to an end. In the field of medicine, that bright spot is the power of knowledge. Within the initial weeks of the first reported COVID-19 case, scientists not only identified the virus responsible for the disease, but successfully sequenced the entire genome. New drug treatments and vaccines are underway. Research is superfluous. What all this proves is that, while global statistics of coronavirus infection may still be rising, knowledge undeniably remains to be our strongest weapon and our beacon of hope. Pandemic or no pandemic, knowledge in the highly volatile world of health care will always guide us through the most difficult of times. One of the main reasons that the Philippine College of Physicians was established is so that internists and other physicians can access new knowledge through continuing medical education. This scientific activity is a perfect example of that. And I would like to congratulate the Philippine Society of Gastroenterology for putting together this informative and innovative virtual classroom. At the end of this session, I hope that your mind is richer and your heart more inspired to become the best of what you do. Thank you.
Thank you, Dr. Mario Panaligan. It is our pleasure to now introduce to you the President of the Philippine Society of Gastroenterology, Dr. Augusto Jose Galang.
Thank you, Dr. Panaligan. A very good evening to all. The Philippine College of Physicians shares a lot of common history with the Philippine Society of Gastroenterology. The late Gonzalo Austria was the first president of both the PCP and the PSG. And so tonight, we are very happy to have the president of the PCP opening our session. And I would like to take this opportunity to congratulate Dr. Panaligan and the PCP for a very successful first ever virtual annual convention that has just been concluded this week. Truly, the challenges we face because of this COVID pandemic will not hinder our collective desire to learn and to educate our members and to nurture them with seeds of wisdom and clinical pearls. So at this point, I would like to formally welcome everyone to this first MAESTRO webinar series. The PSG is proud to present to you a series of scientific presentations beginning tonight and in the next 6 months that will highlight and share with the rest of the medical community the maestros in our esteemed society. We hope that with a successful Maestro webinar series, we will be able to gather ourselves together again as we often do yearly in March. With the cancellation of the 2020 Joint Annual Convention, we hope that this series of webinars will be able to compensate and fill up some gaps in knowledge direct from our master educators in gastroenterology. Thank you very much.
Every masterpiece is born from wisdom. The wisdom of maestros, gained over years of learning, shaped by a palette of experiences. We invite you to feed your knowledge as we light up the virtual stage for a series of scientific takes from the maestros.
Please welcome the brain behind the innovative and artful approach to connect us with the maestros, Chair of the Philippine Society of Gastroenterology Committee on Scientific Activities, Dr. Ian Homer Kua.
Good evening. Thank you very much, PCB President Dr. Mario Panaligan and PSU President Dr. Augusto Segalang for gracing Maestro with your presence and support. The MAESTRO Series is an initiative developed by the Philippine Society of Gastroenterology that offers excellent learning opportunities and brings our accomplished master educators in gastroenterology at the center of this virtual platform. The process of selecting our maestros is based on the following criteria: at least 50 years old and above, a member of good standing of the Philippine Society of Gastroenterology, recognized stature and achievements in clinical gastroenterology, contributions to the Philippine Society of Gastroenterology in leadership, service, and education, recognition as an outstanding clinician by one's colleagues and patients, contributions to clinical science, including scientific publications on clinical topics of merit, contributions to clinical education at the undergraduate, postgraduate, and continuing medical education levels, technological applications and innovation, participation in public education, ethical concerns, and community service, and most importantly, approved by the Philippine Society of Gastroenterology officers and board members. Aside from ensuring that we give you only the finest of maestros, we also made sure that your virtual learning experience will be unique and engaging. As such, this series of master classes is creatively set against different fields of expertise where we might find a maestro, such as the Picassos of painting, the Nobel Prize winners of literature, and the Andrew Lloyd Webbers of musical theater. Tonight, our session transports you to the grand stage of performing arts. Our playbill features a distinguished master educator in gastroenterology who will take inflammatory bowel disease on center stage and give tips on its management. Now, I would like to call on our moderator who will introduce our maestro for today and facilitate our open forum after the discussion. Dr. Judith Gapasin. Our moderator is a member of the Specialty Board of the Philippine Society of Gastroenterology and the Philippine Society of Digestive Endoscopy. Dr. Gapasin has served as the president of the Philippine Society of Gastroenterology and is a fellow of the Philippine College of Physicians, the Philippine Society of Gastroenterology, and the Philippine Society of Digestive Endoscopy. A proud graduate of the University of Santo Tomas, she completed her residency in internal medicine and fellowship in gastroenterology at the St. Luke's Medical Center in Quezon City and her gastroenterology fellowship at the Royal Adelaide Hospital in Australia. Please help me welcome our moderator, Dr. Judith Gapasin.
Good evening, dear colleagues. Welcome to all of you who are joining our substantive webinar. This kind of online gathering is the first of 6 Master Educators in Gastroenterology series brought to us by the Philippine Society of Gastroenterology. To kickstart our series, we are joined by our first maestro. After finishing his gastroenterology fellowship training at the University of Santo Tomas, his passion for gastroenterology pushed him to seek further training abroad. He trained in hepatology, ultrasound, and interventional techniques with Professor Kunio Okuda at Chiba University in Japan, and in therapeutic endoscopy with Professor Nib Sahendra at the University of Hamburg in Germany. He also had visiting fellowships in gastroenterology at the Cleveland Clinic in Ohio and at the Mayo Clinic in Minnesota. He has authored and co-authored 5 book chapters and several original scientific articles in peer-reviewed journals. He is a faculty and convener of a number of Asian-Pacific consensus guidelines, which includes that on inflammatory bowel disease. Our speaker is a gentleman of many pasts, as he was the past president of the Philippine College of Physicians, the Philippine Society of Gastroenterology, the Philippine Society of Digestive Endoscopy, the Hepatology Society of the Philippines, and the Asia-Pacific Association for the Study of the Liver. As a testament of his love for all things IBD, he founded the IBD Club of the Philippines in 1990. In 2018, he spearheaded the single topic conference on IBD by the Asian Pacific Association of Gastroenterology, which brought to the shores of Cebu the giants of IBD. And in 2019, he co-organized the Crohn's and Colitis Philippines, a national IBD patient support group. The good professor's insatiable energy partly comes from interacting with focused, talented, and persevering young minds who look up to him and hope to be like him someday. Unbeknownst to them, he's quite happy to mentor and train them to be better than him. These are unpredictable times, but there are things that are certain, such as death, taxes, and an enlightening and potent lecture from a master educator in gastroenterology. Ladies and gentlemen, it is my singular honor and privilege to introduce Maestro Professor Jose B. Sollano Jr.
Thank you very much for that kind introduction. Before I start, I'd like to thank the organizing committee, headed by Dr. Ian Hua, and of course the president of the Philippine Society of Gastroenterology, Dr. Augusto Dalang, and his board of directors, for giving me this honor to give this inaugural talk in this Maestro Series for the Philippine Society of Gastroenterology. Let me tell you that I'm very, very honored and humbled by this privilege to be able to share with you some of the things that we have learned in inflammatory bowel disease in this country, and hopefully that we'll be able to give you some first today in the management of inflammatory bowel disease. I have modified a little bit the title of my talk by calling it Clinical Pearls in the Management of Inflammatory Bowel Disease, because I hope that at the end of the hour, we will all be able to pick up some pearls in both diagnosis and management in this very, very intriguing and difficult disease that we are facing today and will be facing in the near future. I will start by these basic principles in IBD care. In many healthcare systems, including the Philippines, the frequency of IBD is still rare for it to be managed generally by the family care or the primary care physicians, but still common enough to be part of a community gastroenterology practice as we do it today. While the disease may run a relatively quiescent course, some patients face years of severe and disabling symptoms. The relatively unpredictable prognosis of IBD, combined with the ability of its extra-intestinal manifestations to impact multiple organ systems, requires a nimble and individualized approach to IBD patient management that we need to be able to deliver. With IBD, the treating physician must liaise closely with colleagues in other disciplines, including those of nursing, surgery, radiology, pathology, and numerous other medical specialties that comprise the multidisciplinary team approach that is required for especially the complicated patients with inflammatory bowel disease. Advances in the understanding of IBD pathogenesis and its diagnostic modalities, novel therapeutic options and surgical techniques for CD and UC have fundamentally altered the landscape of IBD management in the past few decades, as we have seen. And our challenge, therefore, as physicians and gastroenterologists in this country who are treating IBD is to leverage these changes to improve patient outcomes while avoiding the many potential pitfalls that lie along the way. And so today, my talk basically is to identify those pitfalls and mistakes so that we'll be able to learn from them, present to you some evidence-based as well as practical tips in the management and diagnosis of inflammatory bowel disease in this country. So I've listed down here about 11 missteps that many of us make, and hopefully that at the end of the hour, we'll be able to clarify a lot of these issues and hopefully help you in the way you manage your patients with inflammatory bowel disease. So let me start with the first and most important problem that we have today, delayed diagnosis. And I already defended it immediately by saying that maybe or perhaps this is not usually a gastroenterologist's error that we check the evidence. The delay in the diagnosis of IBD basically happens in two phases. One is the delay where patients don't bother about their symptoms, and so they don't present to the physician for years, for months, or maybe for decades. And the second phase of the delayed course is the time where the physician is working on the patient, having indecisions whether the patient has IBD or not, and especially in the Philippines, many infectious diseases mimic IBD, and we're stuck in that kind of paradigm. In these three cohorts of IBD patients, we can see, for example, that in this Swiss cohort, in the first part of the slide, of about 1,600 patients, we can see that the diagnostic delay in Crohn's disease is usually longer compared to UC. But you can see that the delay in CD in about 75% of CD patients in Switzerland, for example, where IBD is supposedly not a very uncommon disease, can take up to 24 months before they finally have a good diagnosis. And the contributors, the risk factors for the delay in CD in the Swiss population is the presentation of the disease at less than 40 years old and the ileal type of distribution deletion. With UC, NSAID intake, and the male gender seems to be independent risk factors for delay. In this French CD cohort, it is noted and observed that the delay of diagnosis by more than 12 months increases the risk of the development of intestinal stenosis, fistula and abscess formation, and therefore a lot of intestinal surgeries. In another cohort from Korea, for example, they have seen or they have shown that the diagnostic delay in UC and the diagnostic delay of more than 18 months in CD, the stricturing type, the penetrating type of Crohn's disease were associated with increased risk for intestinal surgery because of the stenosis that happens in these particular patients and it causes a fistula formation. In the Philippines, as well as in many parts of Asia, there's always been this problem about tuberculosis and the differentiation from Crohn's disease. Always a challenge differential diagnosis that we've spoke for the last 30 years in this country, but I hope that we are not in the era of the 1920s anymore, where the diagnosis of Crohn's disease was always leveraged against tuberculosis, as first described by Kennedy Dalzell, and maybe even during the first description of Burrell Crohn of the disease, as he called it, regional enteritis in 1932. Because clearly today we have very good endoscopic differentiations, we have very good clinical characteristics that we can make use, and maybe even laboratory tests that we can make use to create an early diagnosis and arrive at a good way of diagnosing with certainty Crohn's disease versus tuberculosis. Because in that dilemma, in that delay, in that confusion about the diagnosis and the delayed and wrong decisions that you make, there are consequences. In a review of a good database that is present in the GI unit of the AIG in Hyderabad, India, where tuberculosis is pretty endemic like us here in the Philippines, they have shown that the diagnostic delay of more than 18 months are significantly related to higher stenotic disease and therefore more surgeries. And one of the major contributing factor in the delay of diagnosis is the attempt of the clinician. And here you can see that these are patients that have been seen by a group of gastroenterologists. And yet the delay has been contributed by the attempt of the GIs to treat the patients with anti-tuberculous therapy for months. And therefore, when you have a wrong diagnosis, treated wrongly, and therefore a delay in the definitive diagnosis, they all end up with stenotic disease and poor surgeries. And so therefore, if you ask me whether the delayed diagnosis is not a fault of the physician, or especially the gastroenterologist, maybe you put a good question mark on that, because in our experience with the IBD club in this country, still until 2020, there are many delays in diagnosis because there is always this error in making a diagnosis of tuberculosis before we reach the diagnosis of Crohn's disease. And we see a lot of young patients having had surgery because of these complications. The other part, or the other flip side of this issue is the overdiagnosis of IBD. And I think this is usually a gastroenterologist error already. Let me relate to you the experience of my friends from Korea, from the unit of Professor Ye. They have observed that in the last several decades, there's been already a good way and a good skill to diagnose Crohn's disease, and therefore less mistakes have been made in the diagnosis of Crohn's disease and not mistaken as tuberculosis. But as you can see here, there's been a significant increase in the misdiagnosis of what is tuberculosis and initially called Crohn's disease. And therefore, even in specialized centers today, there is this novel problem. The silver lining in this unit, at least in Korea, is that the gap between the wrong diagnosis and the arrival at the correct diagnosis seems to be short, and therefore this is advantageous for the patients. For example, if you have a patient with tuberculosis and you have a very good lab, as the experience of these colleagues of mine in Korea, notice that if you have a good lab and a good pathologist, you'll be able to make a diagnosis, at least from the pathology, of about 50% of your patients, and the other half can be achieved by the empirical treatment success that you give these patients when you treat them with anti-tuberculous therapy, because the clinical picture fits that. So therefore, with this type of practice that we see, the Asia Pacific Consensus on Crohn's disease that we published several years ago has already and has straightforwardly recommended that when you have a patient that you are suspecting to be tuberculosis, but you have difficulty differentiating it from Crohn's, our recommendation is to treat this patient first with anti-tuberculous therapy for 4 to 8 weeks and reassess the lesions and the clinical condition of the patient. And if they are responding, then continue with the treatment. If they're not, then maybe you have to reassess the diagnosis. We do not recommend a concomitant treatment of intestinal tuberculosis in Crohn's disease because we can have issues about evaluations and interpretations of the efficacy of the treatments. Now, what is the problem when you have patients with tuberculosis but initially diagnosed as Crohn's? The next step, of course, is to treat these patients with treatments that are directed to Crohn's disease, and clearly you're going to be using drugs that are all immunosuppressants, steroids, thiopurines, and even infliximab or the biologics. And what happens is that you subject these patients to unnecessary risk of having a florid disease of tuberculosis that can actually may have fatal outcomes. Therefore, these new observations that we are seeing in specialized centers where cases of CD misdiagnosed initially as TB has been decreasing, but the cases of intestinal tuberculosis misdiagnosed initially as Crohn's disease, which is increasing, is a novel problem that we will be seeing today and perhaps, for example, in the near future. Nations have become more concerned about CD due to its increasing incidence, and therefore the threshold to make a diagnosis of Crohn's disease is very low. Beware, because there are still tuberculosis patients in our midst, and we need to have a very good way of distinguishing whether that patient has CD or tuberculosis, so that we don't subject our patients to unnecessary risk of getting harmful side effects of the immunosuppressive treatments that we give them when we treat them like IBD initially. The next misstep that I think is being done, maybe not in the Philippines very much, but at least I think we see this in the patients that we see in the IBD lab meetings, is the misuse and overuse of steroids. You know, Dr. Tulab of the Tulab and Witz era was the first one to introduce corticosteroids in the treatment of ulcerative colitis. And from then on, you can see that the mortality related to acute severe ulcerative colitis has really come down because of the very, very good way of using steroids. However, because of the ease of giving steroids, a lot of our physicians are misusing the drugs because they give a lot of good well-being, feeling of well-being to the patients, very good appetite, and physicians would like to have this in their IBD patients. And so they use this very, very well, and they use this for very long times. But remember, ladies and gentlemen, colleagues, that there is a good, there is a bad, and there's an ugly part of steroids. In a review by the European Crohn's and Colitis Organization, they have concluded that when compared to immunomodulators in biologic therapies, prolonged use of corticosteroids remains a single greatest risk factor for the increased morbidity and mortality in IBD patients. And despite advances in therapeutics, the relative risk of steroids exposure of IBD patients the first 5 years of their disease has remained static at about 50%. And therefore, they have suggested that corticosteroid-dependent patients or those receiving more than one course of steroids in 1 year should be offered treatment escalation to immunomodulators or even biologic therapy. Remember that the achievement of the steroid-free remission is recognized as a treatment target in all the trials that we have done for the new drugs as well as the old drugs, and of course, when we treat patients with IBD in the field or in our clinics. However, the rates of corticosteroid dependency and recurrent steroid prescribing remains high, but haven't really changed over the last several decades. And so therefore, I'd like to remind you that steroids are good, but you need to have a way of using it. And so this particular slide tells you that at least the maximum dose of steroids that you can use, perhaps, especially with prednisone, for example, is 60 milligrams per day. And make sure that you assess treatment response in a few weeks, because you need to taper down the steroids as you go along and get the response that you like. So therefore, let me remind everyone that the use of appropriate dose of steroids to induce remission is key and the first step of using steroids in your patients with acute disease. But you have to have a prospective exit strategy. As we always say in any other disease, hepatitis or in IBD, if you have an entry strategy, you should also have an exit strategy. And using a standard winning regimen to allow prompt recognition of patients who are likely to have become steroid dependent should be well in your clinical practice pathways, so that you will be able to escalate and recommend upregulation of the treatments so that you can avoid all these side effects of steroids. And of course, in the patients where you need to have steroids for some time, make sure that you supplement them with calcium, vitamin D to protect the bones. One thing is very sure, that there is an abuse and an inappropriate use of corticosteroids. But let me remind you that you cannot achieve good remission and safe remission with steroids alone. In fact, steroid-dependent patients who are maintained on remission for a long time usually have very, very high doses of the steroids where they are given for their controlled remission, as the physician believes so. One fact is unarguable, that steroids can be safely given to maintain remission. And so you can induce remission, but you cannot maintain remission with steroids. Here in this table, for example, you can see that, or these graphs, more than 50% of 12 graders in America are able to recognize the bad side effects of steroids. And so if the 12 graders are able to recognize the dangers of steroids, ladies and gentlemen, my colleagues, you must. Therefore, use steroids with caution and use steroids judiciously. The other misstep that I suspect is very, very common, and we see this a lot of times in our clinical practice, is the use of certain drugs, safe as they are, but indicated in the wrong way. For example, aminosalicylates to maintain remission in Crohn's disease. In the highly successful IBD clinical forum in Cebu, where I gave a talk and reviewed the data on the use of 5-ASA and IBD, these are the conclusions that I had, and nothing has changed because 5-ASA is an orphan drug and not many clinical trials are being done in 5-ASA. And the conclusions were that both as an induction and maintenance agent, 5-ASA is a highly effective, safe, and well-tolerated drug for the treatment of mild to moderate ulcerative colitis. Although once widely employed in the treatment of Crohn's disease, current evidence suggests that a much more limited role for 5-ASA is present in CD, and perhaps maybe only in the prevention of post-operative recurrence after these patients have undergone acute resection for the complications of CD. And so in the latest iteration of the ECHO guidelines, which was published just a few months ago, they were very, very straightforward in saying that we recommend against the use of 5-ASA for the maintenance of medically induced remission in patients with Crohn's disease. However, we use 5-ASA in different ways. For example, in my practice, I give 5-ASA for long-term, especially in ulcerative colitis, for the prevention of colorectal cancer, which eventually happens in patients with long-standing IBD. Here in this table, for example, is shown the risk for developing colorectal carcinoma, which increases from 8 to 18% if the patients are with their IBD for 20 to 30 years. The presence of pancreatitis, for example, have an increased risk of colorectal cancer, and the presence of extraintestinal manifestations like primary sclerosing cholangitis in UC gives you a fourfold risk of developing Crohn's disease, colorectal cancer, and the presence of pseudopolyposis and a positive family history for colorectal cancer are also risk factors for the development of colorectal cancer in patients with IBD in the long term. While the understanding of the exact biological mechanisms of 5-ASA in preventing the occurrence of colorectal cancer in long-standing IBD, these are some of the basic evidence that have been elucidated already from the long researches that have been performed on 5-ASA. What is important is that in this latest meta-analysis on the reduction of risk for colorectal neoplasia as well as cancer that was performed by one of us and his colleagues, they have shown that in at least the 31 studies that have reviewed, all evidence, whether coming from cohort studies, case control studies, population-based studies, and hospital-based studies, point to the fact that exposure to 5-aminosalicylates is protective against dysplasia and colorectal cancer. And this reduction in colorectal neoplasia risk was strongest in patients with ulcerative colitis, and there seems to be a dose-dependent benefit as we see this in this meta-analysis. The higher the dose of your 5-ASA maintenance, the lower the risk of developing colorectal cancer in the long term. Therefore, in many of the ECHO guidelines that have been published thus far, they have recommended that mesalamine or mesalazine maintenance treatment should be continued for long term because this may reduce the risk of cancer. The other misstep, and I think for all those who are using anti-TNF in the management of IBD in this country, of course, elsewhere around the world, is the administration of anti-TNF as monotherapy. We know that most of us recommend the combination therapy of anti-TNF plus azathioprine, for example, because it does not only reduce the immunogenicity generated by the anti-TNF biologic, but also it increases the active metabolites of the azathioprine in the immunomodulation that is needed in the control of inflammation and IBD. Why do we recommend combination therapy, even most especially because there is evidence, mechanistic evidence that they can work synergistically. And does it work in the clinics? There is one randomized controlled trial called the Success Study, which showed that the combination therapy is able to achieve significantly a big proportion or a significant proportion of patients achieving corticosteroid-free remission and mucosal healing in 16 weeks with the combination therapy compared to monotherapy alone. How about in CD? Does it work in the clinics? The first publication was an open randomized trial by Gert Jans from Holland, and he showed that early combination immunosuppression with infliximab, azathioprine, and PRN steroids is better compared to conventional step-up therapy by showing to us that the combined combination of infliximab and azathioprine is able to induce remission faster and reduce the corticosteroid dependency of patients who are treated with an aggressive combination therapy from the very beginning. And of course, we quote the very famous and very, very popular SONIC trial, which showed to us that the combination of infliximab and azathioprine is able to achieve a higher proportion of patients getting away from their steroids and being able to achieve mucosal healing in 26 weeks of combination therapy. In a systematic review that was performed about 2 to 3 years ago, they have reviewed all the papers that were done on the use of biologics and combination therapies versus monotherapies. And you will notice immediately that many studies have been done on monotherapies, and only 3 studies were done on combination. 2 RCTs on Crohn's disease. One was the SONIC trial, and of course the other one was the Lehman trial. And of course, only one randomized controlled trial in ulcerative colitis, the Success Study done by Remo Panaccioni and his colleagues. And therefore, what does it tell you? It tells you that yes, while the recommendation of combination therapy is very strong, the evidence seems to be very, very small. And maybe monotherapy is still the way to go. And these are signals that we need to explore. And many guidelines have been actually very careful in just pinpointing the infliximab plus azathioprine combination, especially in CD, and in fact in UC, that was not being taken up in many of the guidelines, including the Asia-Pacific guidelines. But the AGA, or the American Gastroenterological Association guideline, has been very strong in giving a blanket recommendation of a combination biologic plus azathioprine. And sad is the fact that the AGA is a well-respected society and many follow the recommendations. However, 2 years ago, the American College of Gastroenterology was very, very succinct in just identifying that combination therapy with infliximab in immunomodulators may be the only therapy that we need for combination. None of the others may be given as monotherapy. And so this drove the Columbell Group to reanalyze their data in the SONIC database. And in a post-hoc analysis that they did for the SONIC trial, they were able to determine that in all the quartiles of patients where they evaluated efficacy, as long as the patients were able to achieve a trough level of 3 micrograms per ml or more, a good proportion of these patients were able to achieve corticosteroid-free remission and, of course, achieve mucosal healing. And so they themselves were making the conclusion that if adequate drug trough levels are obtained and sustained by therapeutic drug monitoring with infliximab or maybe some other biologics, combination therapy with dipurines may not be necessary to be able to achieve the desired clinical outcomes that we have put upon ourselves in treating patients with biologics. So therefore, in a very good editorial that was published a few months afterwards, this observation is very, very important, and I want you to remember this. In this editorial, Quaid and his colleagues said that this data in the post-hoc analysis of the SONIC trial suggests that the benefit of combination therapy are due to a higher serum level of anti-TNF, the trough levels, therefore, and maybe lower antibodies to the infliximab, rather than to the known synergistic anti-inflammatory effects of the combination therapy. It is ironic that, in fact, the SONIC trial was the first one to be pushing the combination therapy. In this post-hoc analysis provides strong evidence against the combination and favors therapeutic drug monitoring to optimize serum trough levels in patients. Meaning that if you are able to determine trough levels along the treatment course, you can increase the dose of infliximab if the patients are having difficulty in maintaining trough levels. The authors cite these results as hypothesis generating and therefore very interesting for the near future. Nonetheless, I think there is growing evidence to suggest that combination therapy is not necessary in most patients receiving biologic therapy. So, in the latest version of the ECHO guidelines, they were just very specific in recommending combination therapy to infliximab and not to the many other biologics like vedolizumab, adalimumab, and many others. So that if you review the evidence, in fact, both the ustekinumab trial, for example, the latest one, the vedolizumab trial, the Gemini one, and of course the Pursue trial of golimumab, use only these biologics as monotherapies in the treatment for IBD. Another one that really is a sore thumb that we see in all our meetings with the IBD club and maybe even in many of the conferences that you see is the underdosing of IBD medications. And I'm talking about 5-ASA as well as, of course, azathioprine. This is a slide that you have seen in several versions in my talks with you. And I'd just like to emphasize the last point in this slide, that among your patients that you treat with IBD, underdosing of the drug is always very, very common. Let me remind you that if you use 5-ASA in inducing remission, you have to use a concentration that must always be on 3 grams per day. And we recommend at least 4.5 grams per day in order for you to be able to achieve a remission that is fast and sustained. And this systematic review is evidence for that. And usually we combine oral and rectal preparations in order to achieve the outcomes that we like. We always encourage our patients who are on enemas to stay with the enemas because, of course, they're cumbersome. And one way to encourage them in my practice is to tell them that we are using the enema as a treatment, but we also use it as a surrogate marker for efficacy. Because if they're able to sleep with their enemas at night and they're able to contain and control the bowel movement for the whole evening so that the enemas stay with them for the next 8 to 12 hours of sleep, then that's our surrogate markers for efficacy. Because that means that their ulcerative colitis perhaps is already improving. And so you can use this trick with your patients. The other drug that we are afraid of course, is azathioprine, because a lot of myelosuppression happens in these patients, and we today realize that the immunosuppression or the myelosuppression that happens in patients taking azathioprine is because, in the past, because of the TMPMT polymorphism, but today we recognize that there's a new polymorphism called NUDT15, which is actually more common. It's more common among the white population in the West, and of course it is more common also in the East. In this meta-analysis that was recently published, they've shown that the homozygous TT allele carrying patients have a high risk, about 6-fold risk of developing myelosuppression when they are on thiopurine treatment. However, this does not make us become afraid to use azathioprine in these patients, because if they actually are able to tolerate azathioprine, they are going to benefit from the treatment that is going to be given to them. And these are some of the other underdosing practices that we see in IBD. And I'd like to emphasize that we are so afraid about using drugs, and we are so afraid of spending so much for the treatment. But IBD is a difficult disease. And so you cannot treat patients with an expense-driven type of administration. It's because they can only afford 1.5 grams, then you will have to contend with 1.5 grams. they are supposed to be taking their drugs so that they are directed to achieving an intended target. And the intended target, of course, is mucosal healing and, of course, improvement of quality of life. Underdosing of thiopurines is very common because we fear the toxicities. But I will tell you that once you start thiopurines, for example, make sure that you monitor their CDC and their white counts every 2 weeks so that you'll be able to escalate the dose in case they're tolerating it, and of course withdraw the drug if they are not tolerating it. And I quote David Rubin in his famous talk one time in the past. He said that don't settle for what is familiar, cheap, and safe. Don't let your comfort with the safety of the medication be a substitute for confirming efficacy. So let me remind you, therefore, that once you are committed to treat patients with IBD, use the optimum dose and try to monitor the side effects of drugs that you are using so that you'll be able to upgrade or upscale your treatments when they're able to tolerate the drug and withdraw immediately in case they're developing symptoms of adverse events. Lastly, of course, is assessing the clinical presentation of the patient. We know that, for example, in CD, we have this rectal sparing that we always use as a rule of thumb. But clearly, there are some patients with active rectal disease once you see them. And if they are present in a young patient, I recommend that you have to have a very, very aggressive approach to the treatment of these CD patients, because we know that rectal inflammation and deep ulcers in the rectum in patients with CD are predictors of potential fistulizing disease in the future. And so these are going to be your indications for an aggressive therapy and, of course, a very, very regular monitoring of efficacy of the treatment so that they don't develop a very debilitating complication like fistula and anal-necrosis disease. Once we are following our patients who are on treatment, we need to make sure that these patients are taking the drugs and they are having markers of reduce in their a reduction of their inflammation and maybe healing of the mucosa. And of course, they entail some endoscopies. Let me remind you that there are many other ways of employing less invasive and less expensive laboratory and ancillary examinations that can be done to your patients. And we cannot make endoscopy as the only sole metric for measuring efficacy. And I want to combine this with the next topic that I would consider as a misstep again, by just being resigned to treating your patients with IBD actively but not really aggressively, and expect that during the time that you're getting these patients in your offices, they will also develop some exacerbations. We need to control their inflammation very, very well and sustain this control over time by tight monitoring rather than an expectant type of crisis management. The CAM study is a very, very famous study. It showed, for example, for the first time that a good application of the proper treatment and a tight monitoring so that you'll be able to achieve a treat-to-target approach in mucosal healing and improvement in their symptoms is better, as a better strategy compared to upscaling the treatment, because the clinical manifestations that you follow in these patients are the judge of determining whether you upregulate or upscale the treatment or not. By doing regular visitations in clinics of the participating centers, and by using biomarkers like fecal calprotectin and CDI scoring, they were able to show that timely optimization of therapy based on clinical symptoms combined with biomarkers in patients with early Crohn's disease results in improved clinical endoscopic outcomes in this particular strategy towards achieving good control and good achievement of treatment goals. Let me tell you, for example, that fecal calprotectin is a very stable protein. It is a good marker that has a strong association with disease activity, with reduction in serologic markers, for example, endoscopic activity of patients in inflammatory bowel disease. It has a very good sensitivity and specificity, especially for ulcerative colitis. And there are point-of-care tests today that are available. In this country, for example, there's already available quantitative determination of fecal calprotectin. And so you can have a very good way of interpreting data and be able to apply this in your patients that you see in a clinical practice. In all these Asian papers that I have reviewed, fecal calprotectin appears to be a reliable marker and a good non-invasive monitoring strategy for disease activity, particularly in ulcerative colitis, and can replace endoscopy as a good way to follow up with patients. This particular schema tells you a good example of how to apply the tight monitoring and good control of patients that you are following up with IBD, for example. Upon the diagnosis of IBD that you have committed, whether Crohn's disease or ulcerative colitis, we recommend that you also determine the fecal calprotectin of these patients, maybe do a CRP determination as well. And of course, as you can see here, repeated visits at close intervals are key in the tight control of these patients. And you can see here that we recommend, for example, the use of transabdominal ultrasound. This is non-invasive, very, very available, always available in your centers. And you can use this in conjunction with your fecal calprotectin and your CRP on regular intervals at different visits in your clinic so that you will be able to assess the response of the patient's colon or small bowel while you are treating them for their IBD. And only do your endoscopies at 3 or 6 month intervals to be able to assess for mucosal healing and, of course, for resolution of ulcerations. These are some of the cross-sectional imaging assessments that are available in inflammatory bowel disease today. In the Philippines, you can have CT enterography, and I prefer, of course, MR enterography because of the less radiation that you give to these patients. And here you can see that MR enterography is able to determine areas of inflammation and even areas of strictures. But clearly, of course, MRE is very efficient, but very expensive. So in the right picture, for example, you see that these strictures and this stenosis can also be diagnosed quite efficiently by just abdominal bowel ultrasound, as you can see in this particular picture here on the right. It can have transabdominal ultrasound is able to tell you the changes in the thickness and the ramification of the layers of the colon, as you can see in this cross-sectional picture of the ultrasound of a colon in a UC patient. And the right picture here on the upper squares correspond to the same area where this ultrasound was seen. This is also seen in the CD patients in these 2 squares in the middle. And you can see, for example, that if you use Doppler in these patients, you can see the hypervascularity that happens in the very inflamed mucosa and submucosa of patients with active disease, and the disappearance of that when they are responding very well to the therapy. So transabdominal ultrasound, therefore, is very cheap, it's very available, and a very good non-invasive way of following up your patients as you monitor them tightly while they're undergoing treatment. These are the evolution of the goals of treatment in IBD and the key steps that we have seen develop over the several years that we have been doing research in IBD. Clearly, our goals have not changed. It is clinical remission, and clinical remission really is defined as the control of intestinal inflammation and then normalization of the life of the patients. And in the trials that we have seen, for example, the CAM trial and the subsequent trials that have followed, we have seen that biochemical and endoscopic remission can be achieved by monitoring both the fecal calprotectin and by endoscopic evaluation. But today we're using cross-sectional imaging like MRE, CTE, and of course transabdominal ultrasound. We'll also be able to increase that efficiency of diet monitoring while the patients are on treatment. While we are not yet ready to recommend histological healing or histological remission as a key target in the eventual goal of therapy for our patients with IBD, today we recognize already that we can rely on patient-reported outcomes on their symptoms as a way of determining which patients are responding well and which patients are going to need escalation of their therapies. These are some of the composite outcomes that are or targets that are recommended in this ERO inclusion in our treat-to-target approach that has been recommended by the STRIDE group. STRIDE, of course, is a group of very well-known experts in IBD in the world, and they are recommending to us that in this particular focus on the treatment of IBD, we have to have some targets. And the targets, of course, in processes is to treat the patient and, of course, to treat the intestinal inflammation. In treating the patient, the assessment of these targets are important. And these are the resolution of abdominal pain and the normalization of bowel habits as the target that you need to achieve when you are treating these patients. And of course, you have also to target the intestinal inflammation by treating them adequately. And the assessment for achieving these targets are either an endoscopic documentation of the absence of ulcerations and resolution of those ulcers, or by a cross-sectional imaging like CT or MR, in order for you to be able to show that you have in fact healed the ulcers and has controlled the inflammation. What is good with cross-sectional imaging, especially in Crohn's disease, is the fact that you'll be able to assess not only the colon, but of course the small bowel, which is important in the follow-up and very, very tight care of patients with IBD or especially Crohn's disease. As of the moment, the use of biomarkers and histology are not yet targets because the data is not yet very robust. But I will suspect that in the future it will become also a target that we need to evaluate. In Crohn's disease, in ulcerative colitis, the targets are the resolution of rectal bleeding and of course the normalization of bowel habits as patient-reported outcomes that you need to assess and be able to achieve as a target of therapy when you are treating ulcerative colitis. And the other target, of course, is mucosal healing that you can more or less evaluate by endoscopy. In this particular instance, because ulcerative colitis is only occurring in the colon, maybe a colonoscopy will be good enough in assessing mucosal healing in this cohort of patients with ulcerative colitis. Again, we are not recommending fecal calprotectin in histology as targets today for efficacy of treatment, but I will suspect that when the data is there, it will become part of the recommendation as well. Another misstep in another mistake that I think us gastroenterologists are committing in our care for IBD patients is to stay away from the surgeons. And we regard surgery as an outcome of failure, or as an outcome that is indicative of failure. I would recommend, however, that there are some patients that when you see them for the first time, actually maybe are needing surgery, or when you are following up these patients, you will be able to tell yourself that yes, these are the patients that are not responding to my treatment and therefore may need surgery, and that should not drive you away from the surgeons. Because there are clear indications where the surgeons are always going to be helpful in our total management of IBD. In perianal Crohn's with very, very bad fistula in ano that are really impacting the quality of life of these patients. These patients need Ceton, for example, and they need a combination of your surgery and, of course, biologic therapy in order to be able to achieve the outcomes that you like. In patients with toxic megacolon and their very acute, severe ulcerative colitis episode or perforation that happens in these conditions, you need the surgeons. And that is why when we are treating patients with acute disease, we always wanted a multidisciplinary team to assess the patients. The stricturing or penetrating Crohn's disease, perhaps they belong to the surgeons. active disease that are refractory or intolerant to medical management, especially if they're already on high-dose biologics. A chronic steroid dependency that you cannot correct with your biologic therapy, for example. And the presence of neoplasia and adenocarcinoma clearly belong to the surgeon. However, today we know that we are able to do this endoscopically, but in the more wide and the more deep lesions, the surgeons need to be called. And clearly, of course, in children who are in very bad Crohn's disease, the failure to try may be a good indication for consulting the surgeons. We know, for example, that a lot of our patients can be treated in the outpatient, but in the patients with acute disease, we need to confine these patients. And when we confine the patients, please remember that you need to anticoagulate this particular group of patients because there's always a danger of venous thromboembolic disease in patients who are hospitalized. This is the one study that tells us that there is a substantial group of patients who will develop both venous and even arterial thromboembolic phenomena, and this can have very, very fatal or severe complications once you throw away some of those emboli to the lungs or to the brain. And almost all the guidelines that are published have always recommended prophylaxis for thromboembolic disease in patients with acute IBD attacks. And you can use either mechanical thromboprophylaxis or medical thromboprophylaxis in the form of low molecular weight heparin, stockings, or even perhaps some filters. Because in all the guidelines that we have seen so far, it is recommended that all patients with an acute IBD attack or hospitalized need prophylaxis. Even those patients who have been confined not for an IBD, but other illnesses, as long as they have acute inflammatory conditions or are going to be subject to long days of hospitalizations, need to have some prophylaxis. Even in patients where there is some minor bleeding, we also recommend prophylaxis. Only in the patients where there is severe bleeding that perhaps if you cannot do heparinization, then you might have to give them filters or maybe give them or subject them to some mechanical thromboprophylactic strategies in order for us to prevent venous thromboembolism phenomenon. And of course, when they are already out of their bleeding episodes, then you might also administer your heparinization in these particular patients. Now, second to the last, of course, is this inability or this displeasure or the intended forgetfulness of not talking about certain personal stuff with your patients with IBD. Not talking about sex, not talking about vitamin D supplementation, and maybe vaccination. I don't want to deal with vaccination because we have already recommended that many times in our talks, but let us talk about the sex life of our patients. For women, I think the sex life that is, or the issues are related to sex in this particular gender is pregnancy. And it is always important to emphasize to our patients that yes, they can always consider pregnancy as an option. And it is important that they are in good control of their IBD before they are going to even consider conception. Because in pregnancy, in IBD, timing is everything. If they are pregnant, if they become pregnant, when their disease is well under control, their outcomes of pregnancy are always better compared to when they have an exacerbation or they develop an exacerbation when they're pregnant, or they become pregnant at the time that they have exacerbations. In the Piano Registry, which is the biggest registry of pregnant women today that is being accumulated and supervised by UMA, they have shown that some of these medications that we are giving to our IBD patients are quite safe. For example, in the Piano Registry, IBD patients that have been subjected or exposed to biologics have only a very slight risk of having spontaneous abortions, cesarean sections, and maybe sending their babies to the NICU after delivery. And of course, in the Piano Registry also, they have determined that steroids may have a deeper impact on these patients. preterm birth, low birth weight, and of course gestational diabetes has been associated with the use of steroids during pregnancy. But the most important fact is that infections or congenital malformations and developmental delay seems to be not related to or not risks that are associated with steroid exposure during pregnancy. And so therefore, inflammatory bowel disease increases the risks of pregnancy complications and adverse pregnancy outcomes, and active disease exacerbates these risks. So make sure that your patients are in good control before you talk about pregnancy, and always encourage pregnancy if they want to raise a family, and always make sure that they're in good control. Active disease and pelvic surgery reduce female fertility, and fertility is preserved with quiescent disease. However, patient misconceptions about fertility, disease risks, and medication safety contribute to the voluntary childlessness of these patients. So always make sure that your female patients are aware that they can become perfect mothers as long as their disease is under control. Most medications have a favorable safety profile for use during pregnancy and breastfeeding, but however, there are some risks that are seen among patients who are taking steroids. Patients should be counseled about the importance of medications adherence to optimize disease control before conception and to maintain remission during and throughout the pregnancy. How about the men? The men, of course, their concern is about their virility and, of course, their function. And this review of our Korean colleagues are very, very important, because I think in the care of IBD patients, we need a holistic approach so that they'll have a good quality of life. And I have here a table which shows to us that indeed in those patients who have total proctocolectomy or IPAA, yes, there is some degree of sexual dysfunction. Notice that retrograde ejaculation, erectile dysfunction, and sometimes dyspareunia can be seen from 3% to as high as 12% in these patients who have an IPAA. And of course, in patients with stoma, these erectile dysfunction issues and sometimes decrease in sexual appetite has been observed. But as you can see in these pictures, there's life after a stoma or there's life after an IPAA, because these individuals, for example, are so proud enough that they are able to have a normal quality of life, a normal interaction socially, and you cannot end up with just a very, very bad sexual experience. And I have highlighted two studies, for example, coming from two centers, where they reported that in their cohort of patients who have had an IPAA, they have very favorable results. In fact, in one center, for example, there was a 2.1 point increase in the erectile function of these patients. There was no significant difference between the pre- and post-operative erectile dysfunction in the patients that have had an IPAA. And so, therefore, if you have patients that are very, very concerned about their sexual function after surgery, maybe you can look out for these two centers and refer these male patients to them, so that at the end of the day, you have a happy doctor, a happy patient, a happy life, because you have a happy wife. Vitamin D, of course, is one that we forget, especially in patients who are on steroids. But let me remind you that in patients with IBD, vitamin D deficiency is very common. And vitamin D supplementation is important because vitamin D is able to increase or decrease the disease activity and inflammation in bowel. It also decreases healthcare utilization. And of course, decreases clinical relapse in IBD. And this analysis supports that observation that indeed, when you supplement vitamin D and IBD therapy, you will have reduction in the relapses of the disease. Lastly, of course, are special situations. In this particular talk, I always mention COVID-19. I think in COVID-19 and SARS-CoV-2 infection, what we recommend is that all of your patients should stay on their IBD medications as much as they can, because in these times of COVID, we need to have a tight control and good control of the activity of the disease. So that in all these patients, even if they are taking medications that are supposedly have immunosuppressive effects, make sure that they stay with their biologics, their immunosuppressants, and their JAK inhibitors. What we always found, however, is the use or the continued use of steroids, because we know that in patients who are receiving steroids more than 20 milligrams per day, they're at higher risk of developing SARS-CoV-2 infection and maybe COVID infection as well. Once, of course, a patient develops COVID, we recommend that you reduce or you stop thiopurines, methotrexate, and intofacitinib, and also stop their biologic therapy during their acute attack of COVID. However, in these patients who are able to survive COVID, you need to reinstitute and re-administer your biologics when they are free and they are able to survive their pulmonary infection. The Asia Pacific Association of Gastroenterology has published a consensus statement on the use of and the control of IBD in the times of COVID, and they're very straightforward in this particular recommendation. And we said that during this COVID pandemic, maintenance of disease control should be the main principle of therapy. There is no evidence that current therapies for IBD increase the risk of SARS-CoV-2 infection or the development of severe COVID. In fact, some therapies like anti-TNF-alpha, anti-IL-6 may conversely have a beneficial role in ameliorating severe COVID-19 disease, because in this cohort of patients receiving these drugs, sometimes the cytokine storm is mitigated. Therefore, IBD patients should not discontinue their current therapy, and most therapies can be safely initiated even in these times of COVID-19. I will end my talk by discussing a little bit about novel treatments in IBD, and we are thinking that this approach of IBD in these times really are paradigm changing. If you know about IBM Watson, which is the Watson project of the Big Blue Corporation, they attempted to use big data to utilize this in disease management. But of course, they had encountered problems, and today the Watson project of IBM has been shelved. But there are many other platforms of artificial intelligence where we are able to now connect some of the biggest databases and some of the clinical trials that are pivotal, and even data from social media, filtering into these big data platforms that are now projected to produce a lot of benefits to the patients and to the healthcare system that are enumerated here in the lower part of the slide. In fact, in a recent review just published a few months ago, a lot of opportunities and challenges are already identified with the use of big data and big machines and artificial intelligence in our fight against disease and, of course, proper delivery of care. The only key requirements, however, and still is a big issue, is to be able to generate good quality data that is standardized in form, because many centers use different ways of inputting data. And I think the other requirement, of course, is the expertise to identify or employ tools that are able to generate and integrate data and able to interpret this properly for clinical application. I have enumerated here some of the things that already are happening with AI-assisted delivery of care in radiology, in pathology, in our war against antibiotic resistance. But I think in some ways there are also a lot of glitter in IBD, because today there's also a new concept in the treatment of IBD, and this is about reshaping or shaping the future of preclinical IBD. Today, there are companies like J&J employing different species of Clostridium difficile in order to identify the patients who have yet no IBD but already have been identified by AI, for example, or by this big database related investigations, to identify the patients who may develop IBD in the future. And by giving this new species of microbiome re-engineering, we'll be able to intercept the formation and the development of inflammatory bowel disease in the future. So today there's this new concept about intercepting inflammatory bowel disease so that the patients who are vulnerable will never develop IBD as they become adults. These are some of the conceptual changes that has occurred in the last 20 to 30 years of our study of the approach to the diagnosis and management of the inflammatory bowel disease that has happened in the 21st century, from its clinical presentation and of course, towards the optimum management and strategies to be able to achieve a more holistic treatment approach for inflammatory bowel disease. But the major change in concept we have achieved in this country, however, is the acceptance of the clinicians as gastroenterologists, that our dogged pursuit and our perseverance to study the clinical presentation of ulcerative colitis and Crohn's disease is now an accepted concept that really indeed inflammatory bowel disease occurs in the Filipino patients. So today, therefore, I'd like to conclude by this slide. In many parts of Asia, the Philippines included, as in Western countries, the incidence of IBD is increasing exponentially, although still lower compared to Europe and North America. While there are several differences in the phenotypic characteristics of IBD between East and West, its natural history, its response to aminosalicylates and biologic therapy, and disease evolution over time appears similar to those reported in the West. Due to the many confounders, however, challenges and difficulties in diagnosis and disease management contribute to delayed diagnosis, inadequate treatment, and thus the resulting high rates of complicated disease and surgery. Today, we reviewed several of your real-world diagnostic and therapeutic struggles, and hopefully I was able to offer to you evidence-based as well as realistic pearls in the optimum care of our patients with IBD in this country. I am fully grateful, and I feel very happy that I was given this privilege to give this Maestro inaugural talk. On behalf of myself, and of course on behalf of my family, I really appreciate this gift and this reward of affirmation for all the 30 years of work and toil that I have done with IBD in this country. And from the bottom of our heart, my family and I would like to thank the PSG and of course the organizing committee for this particular privilege. On behalf, of course, of my IBD club family and all the fellows that have come and gone and assisted me in the IBD meetings, from them and from my heart, I say thank you to PSG. Salamat po na marami.
Thank you very much, Dr. Sollano, for such a masterful delivery of an excellent lecture on a very intimidating and challenging GI disorder. We have so many questions for you, Doc. So if you could just indulge us for a few more minutes.
Can you hear me now?
Before?
Can you hear me?
Yeah, okay. Yes, Doc, I can hear you. Okay, so before I start with the question and answer portion, I would like to inform everyone that after this lecture, when you exit, you will be directed to a page in which we are kindly requesting you to answer our short survey. You know, this is quite helpful for the organizer, so it would be great if you could answer that short survey. So to proceed, Professor Sollano, there's a question here that says, or that asks about 5-ASA as a cancer prophylaxis. Do you still use this among your patients who are requiring other medications to control UC? I suppose he's saying that if the patient is on another medication, are you still adding on 5-ASA because of its role in cancer prophylaxis?
I think what you're referring to the patients who are on biologics. If they're getting good control with biologics, I think that control of inflammation, and if you can sustain the control of that inflammation by long-term biologics, then you will be able to achieve the same goal as what you achieve in ulcerative colitis and 5-ASA. Problem, however, is that if you want to have that kind of strategy for maintaining the inflammation with a very expensive drug, then patients will not be able to sustain that. And so in a lot of my patients who are on good remission, we maintain them with 5-ASA because at least this is a more affordable drug and you can deliver this drug for a longer time, and therefore the benefits will be, I think, more, much more compared to very short-term control of inflammation because of expensive biologics.
All right. We have a question about therapeutic drug monitoring. Do we already have that in the Philippines, Doc? I suppose this is for the, when we're trying to get the trough levels of the thiopurines.
That's a very good question. In fact, all the data that we are saying is, yes, if you're able to do trough levels, then you may not have to combine treatments with biologics and thiopurines. Unfortunately, at the nearest that you can have drug monitoring is Singapore. But we are trying to have some arrangements to have some drug monitoring with small machines in the Philippines. And hopefully we'll be able to do that in the next year, COVID notwithstanding, of course. But I think once the trough levels and drug monitoring facilities are available, I think that is the good step, a key step in trying to be able to induce remission very fast by giving you by making the patients achieve the trough level while they're on treatment. A colleague of mine in Singapore, for example, administers his biologic now and then determines the trough level in 1 hour. If he doesn't get the trough level that is desired, like say 3 or more, then he adds another biologic dose in the same day. In that way, you assure that you have the efficacy of the drug and the benefits of the patient.
With the fecal calprotectin, you mentioned that we can use this as a non-invasive marker of a possible endoscopic finding. So in the books, it is said that if it is more than 250 micrograms, it is predictive of relapse. If it's less than 50 micrograms, it's predictive of remission.
Yeah.
Are you using the same value, Professor?
I have only used, because today the availability of quantitative fecal calprotectin is only like 1 month or 2 months old. In fact, maybe not 2 months old. Just before the lockdown, one reference lab was offering that. And I have only used that to 2 patients. And I'm still fighting them because it's so expensive. It's like 8,000 per determination. I said, you need to push this down to about 2,000, around the range of 2,000, so that we'll be able to use this clinically. Because at 8,000, that's really expensive. But I think if you want to use fecal calprotectin,
that's going to be prohibitive.
Yeah. So if you want to use fecal calprotectin, yes, use it as long as it's cheap, and then use it frequently, because then it is really, really a good biomarker for decreasing or increase it's a good biomarker for intestinal inflammation. And in this particular instance, you can use this as a non-invasive way to test for that, response or no response. The another, of course, is transabdominal bowel ultrasound. I think bowel ultrasound is very, very common. You can use your usual ultrasound machine if you have a very good ultrasonographer, and this is even less expensive and less cumbersome.
In connection with the transabdominal ultrasound that you mentioned, Doc, don't you think that this requires a little bit of expertise? I mean, I suppose not all ultrasonologists are quite adept in interpreting these findings, and ultrasound is quite subjective. Is this a field that our gastroenterology fellows can go into, or is this restricted to the radiologists?
I think if you look at all the centers in Asia today, most centers who are doing IBD are basically GIs, and maybe a subspecialty we call ibidology, and they all do their own ultrasound. This takes a lot of skill, and therefore you need a little bit more training, training the steady hand, and of course training the eyes. But yes, this can be done by the gastroenterologists.
Fantastic news. There's a question here, Doc. How do we avoid delay in diagnosis? I think this is quite broad, but how do we avoid delay in the diagnosis?
I think one is, we always say, and we have always repeated this in our talks, the first step towards the early diagnosis of IBD is to suspect IBD. All right? However, as you can see in that particular study that was done in Korea, if your threshold to make a diagnosis of IBD is very low, then you also get that overdiagnosis phenomenon in IBD. So today, therefore, by using your clinical symptoms, we say always, if you have a young patient who has a lot of abdominal pain, a little bit of bloody diarrhea, and in one IBD meeting that I had a massive GI bleeding in a young patient like 18, 20 years old that you cannot understand where they're coming from. Maybe these are some manifestations of IBD. And so when you are suspecting IBD, work up the patient properly. And when you say work up the patient properly, it's not really just about endoscopy. Because endoscopy will be able only to determine and detect ulcers for ulcer colitis. In prosthesis, you need to evaluate the small bowel. And so if you need to evaluate the small bowel, cross-sectional imaging is important and part of the workup. So early workup and early suspicion of IBD is important. The use of other biomarkers are also important in the diagnosis. And do not always blame TB or do not always blame amoeba, because in patients who have repeated episodes of quote-unquote amoeba like 3 times a year, that is not really amoeba. Amoeba doesn't come back in three times a year. That's a fallacy. And so early suspicion and a complete workup will mean early diagnosis.
We have a question, Doc. Who does IPAA in the Philippines?
Oh, you need to have some colleagues who does very good colorectal surgery. I have a colleague in my team today that does IPAA. In his latest talk, he has, of course, there's not many. I think he has done 8 already, and 6 had a very good outcome. Some, of course, do not expect that your diarrhea will be resolved or your diarrhea will be a problem in the first 6 or 8 months of the patient's existence. But at least there are people who are able to do IPAA in this country. Yes.
Another question is vedolizumab recommended on?
Jen, for what?
Yeah.
I think for our colleagues who are practicing in the province
Yes,
or the big cities, what you need to do is you team up with a very good surgeon who has a mind of an internist, but the skill in the hands like a surgeon. Because these are the surgeons that you like to cooperate, you like to nurture them, you like to grow with them, and encourage them to do very good surgeries in your centers. Because you cannot always send your patients to Manila or to Hong Kong or to anywhere. You have to cultivate and make your team grow within your facility so that you will develop your own multidisciplinary team that can address all the problems of IBD.
That's a very valid point, Doc. Corollary to that, do we have, for example, our society, are we in, let's say, do we have like a sister center, that we could, ask help from, or in terms of engaging their expertise with regards to inflammatory bowel disease? Do we have something like that, like some sort of arrangement? Or is that possible that someday that we could do?
Not yet. In fact,
to share cases.
Yeah, we were encouraged one time when I forgot the guy now. I think Henson something. One of the young guys of Suang in CSK in Hong Kong came to give a talk, and he was very impressed with the IBD club. And so when I met Sue a few months later, she said, "Oh, why don't we collaborate and do this thing together?" When you are in a conference, this idealism always is very high, and this interest to cooperate is very high. But when you come back, when you get involved in your clinic again, and you're rushing with your endoscopies and you're rushing with your patient care, all this other stuff disappears and dissipates. And so I think during this time of COVID, let me remind me, because I think we can cooperate with the Chinese University of Hong Kong. We are good friends there. We can cooperate with, say, NUH. David Ong is a really good friend of ours, and there are some colleagues of ours here that have worked with, say, Star and Carla have worked with David Ong. And so we can collaborate and later on maybe deliver multiple center type of care into our local patients.
There's a question, Doc, about vedolizumab. Is it recommended on patients who are undergoing hemodialysis, and is there a dose recommendation for this?
I'm not very aware about those adjustments in vedolizumab and dialysis. I don't have a good answer for that.
All right. There's a question about a clinical question. Is there a differentiating sign or symptom of IBD versus that of TB that will clinch the diagnosis? Is this, so, if laboratory examinations or histopath are very inconclusive, is there like a clinical sign that will clinch the diagnosis that this is IBD rather than TB or vice versa?
I think most of our tuberculosis patients that we see with GI tuberculosis are kind of old. If you see our patients with Crohn's disease, they are young. In fact, as young as 5 years old or 8 years old. And some of these patients that we are seeing now especially are like 20, 25 years old. A lot of them, at least because there's a bias in the patients that I see, a lot of them have been operated. It's so unfortunate. So you have younger patients with IBD compared to tuberculosis. Second is that most of your patients with tuberculosis always present with some of these smoldering fevers and loss of appetite that is always related to tuberculosis. And in many patients have also pulmonary tuberculosis as additional evidence. They don't have rectal bleeding as often as patients with IBD. So these are clinical characteristics or clinical phenotypes of these patients that make you identify which one is probably Crohn's and which one is probably GITB. When you do your endoscopies, that is where sometimes much of the evidence also are added up, because clearly patients with tuberculosis will only have ileocecal lesions. In CD, for example, you have skip lesions, and you have wider ulcers in TB, and you have more serpiginous ulcers in CD, and you have cobblestoning in CD, and you don't get the cobblestoning in TB. So these are little nuggets that you can put together when you are doing your clinical investigation as well as your endoscopic examination, so that you'll be able to cleanse a better way of differentiating between the two diseases.
Professor, do we do TPMT genotype in the Philippines? Do we check the genotypes of our patients before we start them on thiopurines?
We don't have TPMT, but let me advise you that don't worry about TPMT. TPMT is less common compared to the NUDP15 mutation. There are more NUDP15 mutations in Asia as well as in the world compared to TPMT. But the trick is that whether we know that there is more or less NUDP15 or TPMT mutations among our population, you cannot stop yourself from giving azathioprine. Because the trick is, start your azathioprine, monitor your CBC, your white counts over time. If you're so nervous and so anxious, you do your white count determinations every week. I do mine every 2 weeks. And in the patients who are able to tolerate, you continue the dose of your thiopurines, even increase it if you need it. But in the patients where they exhibit immediate toxicity, then you can withdraw the drug, because withdrawing the drug makes that adverse event disappear.
You mentioned, doctor, about that at the moment we're not really aiming for the histologic clearance of the disease, and that at the moment we're relying more on the patient-reported outcomes. But isn't it true that clinical symptoms do not usually correlate with endoscopic findings? I mean, we have some patients who appear very benign, not toxic looking at all. And then when you take a look at them endoscopically, they have lots of serpiginous ulcers and very friable mucosa. Can you comment on that?
Interesting observation, Jet. In fact, you are talking about Crohn's disease more often compared to ulcerative colitis. In Crohn's disease, a lot of patients will have CDI scores of 100 or less, or maybe even 150 or less, and they're all on remission. But CDI is quite only on symptoms. And therefore, we know in CD that the symptoms do not correlate with endoscopic findings. And therefore, we say that you can follow up your patients with pure history and physical during the clinic follow-up. We recommend today, for example, fecal calprotectin, because when the patients have fecal calprotectins that are high, you know that there's still an ongoing inflammation. And the advice, of course, is not to scope them immediately, but then you have to schedule your endoscopy at 3-6 months intervals while on induction and, of course, early maintenance phase. because clearly when you rely on CDI and there are symptoms, you cannot detect the intestinal ulcers and inflammation. And this is why we say, okay, fecal calpro, transabdominal bowel ultrasound are important, aside from, of course, endoscopy. And therefore, when you ask me, there are some patients who will have no symptoms and yet they have bad ulcers. Yeah, that happens. But this happens more often in patients with CD. And you see a lot of patients who have ulcerations in the colons, whether proctitis or colitis, they are going to be very, very symptomatic. In fact, we have patients who have responded to even biologic therapy. They don't have ulcers anymore, and yet they're still having a lot of diarrhea. So most of these patients with UC are quite symptomatic, even if they're already in some good mucosal control. So in CD, you have to be very careful about the dissociation between symptoms and ulcerations, and so you need other things that you need to do to be able to determine that the asymptomatic patients are also having mucosal healing. Now, histologic remission is not yet there. We don't have very good way of a standardized interpretation of mucosal or histologic remission. We have one now, for example, basal plasmacytosis disappearance in the Gibo score. We are still validating that, but I think a lot of pathologists are using that already. And that can be a very robust way of determining histological remission that can be translated to symptom relief or long-term control of disease, then maybe histologic remission will be also a target in the future.
All right. Thank you so much, Professor Sollano. I still have a lot of questions here, but I think it's time to wrap up. But before anything else, may we ask you for a few words to our trainees, to our young gastroenterologists who are probably keen on going into this subspecialty, such an interesting up-and-coming specialty, very promising in terms of treatment. So any last few words, Professor?
Yeah, there's a subspecialty now called ibidology. And therefore, if anyone wants to have a niche in gastroenterology in this country, you go that pathway, because a lot of you will benefit from your early interest with IBD. Mine was tough and long, 30 years. I had to prove it to myself, prove it to my colleagues, and then now that it is accepted, and I'm happy that people are recognizing that. And I really am happy that I was able to achieve that in my lifetime. Now, IBD is such an intriguing disease, but there's so many advances. IBD is one of those diseases in GI where basic research has been translated to clinical care. And that is so exciting. And as we understand the molecular basis of the disease, we even become better. And now there is this new strategy called intercepting IBD, a very, very nice and very challenging concept where you can prevent IBD from happening if you do some microbiome re-engineering or do other interventions in the future. So I am fighting the PSG for extending okay, I'm very open now. I am fighting the PSG for extending the fellowship program to 3 years, because I thought and I always believe that nobody can learn additional GI on the 3rd year. So if you're going to do a 3rd year for GI programs, then do IBD for 1 year, do your other disciplines like hepatology for 1 year, or do other stuff than GI. And maybe this is where we can meet halfway. So IBD is exciting, and it's going to remain exciting and challenging for the next 100 years.
Again, thank you so much, Professor Sollano. Really, really fantastic lecture. I'm sure that everybody learned quite a lot this evening. At this juncture, I would like to hand over the screen to our next speaker, or to our colleague.
Thank you to our maestro, Dr. Jose Sollano Jr., and our moderator, Dr. Gapasin. To close this Maestro series of webinars, we call on the first Vice President of the Philippine Society of Gastroenterology, Dr. Ira Yu.
Every chance to learn from a maestro is definitely worth taking. We would like to thank everyone who joined us tonight for this webinar. This is just part 1 of the PSG's MAESTRO Series. Our next month's webinar is entitled Mysteries in GI Bleeding, Tools, Techniques, Tips, and Tricks. So you see, it's very easy to remember the 4 T's. And for us to learn more about these 4 important T's, our next maestro is Dr. Virgilio Bañez. So we would like to see you again for his webinar on a Saturday, that's September 19. We will be later on sending you a link to the registration for this upcoming webinar. We would also like to announce that for you to stay informed and updated about all the events, the Philippine Society of Gastroenterology will be launching its very own events app. This will make it very convenient for all of us fellow gastroenterologists to schedule and stay updated regarding all our programs and activities. Finally, please do not forget, okay, just like what Dr. Gapasin said earlier, we would like to remind everyone to complete the evaluation form for your CPD, CME units. So again, on behalf of the Philippine Society of Gastroenterology, thank you all for joining us tonight. We look forward to bringing you more of this state-of-the-art webinars. So see you all again and good evening.
On behalf of the Philippine Society of Gastroenterology, we would like to thank the following pharmaceutical partners. Our gold sponsors, Natrafarm, Westmont. Our silver sponsors, Cathay Drug Company, Pharma Nutria, SV Moore. And our bronze sponsors, Abbott Nutrition, Fujifilm, Just Right, Kaufman Pharma, Multicare, Mylan, and Servier. Please save the date for the Philippine Digestive Health Week, happening on March 8 to 13, 2021. You are all invited to join, advance, and collaborate. Let your guts take you to a new level as the Philippine Society of Gastroenterology connects us to new information and insights in this online convention. Visit www.psgastro.org for more details. Thank you, ladies and gentlemen. Please join us again on September 19 when Maestro unravels the mysteries behind GI bleeding. Another virtual lecture that's one for the books. Enjoy the rest of your evening.